All right. So last time we started a rapid boards review boot camp, so to speak, where we went through, I think, a little over 100 slides of derm path cases. And today I'm going to kind of do the same thing, but with Kodachromes. So back in the day when I was studying for the applied exam, I think what I did, it's a little fuzzy for me to remember precisely, but I went through Alikhan, and I think any bolded term I looked up and kind of just ripped representative photographs and then put on the next slide what it was. So I could just kind of flip through a PowerPoint of Coda and then get immediate feedback on what it was and just kind of roll through a bunch of slides. Like my Derm Path PowerPoint that was 1,200 slides, this is also 1,200 slides. So I figured I would just go for, I don't know, till I get bored, 100 slides or 10 minutes or whatever keeps attention. And then we'll go from there. Just a disclaimer, these are not my images for the most part. I haven't reviewed this in 5 years, so we're going to be kind of flipping them through them and re-reviewing and learning together. So the first Kodachrome, we have a patient here with red patches, lakes of coalescent pus, and a little bit of nail dystrophy. So this is a localized form of pustular psoriasis known as acrodermatitis continuum of Halipo. And the key there is the coalescent lake of pus and nail dystrophy. So it looks like we're probably in the psoriasis chapter, so we're going to power through some psoriasis findings. Here are pits. This is nail pits. Remember, pits and psoriasis indicate matrical disease, so dorsal nail plate for the proximal nail matrix. This is an oil spot, what I'm indicating here. There's also distal onycholysis. An oil spot is due to nail bed psoriasis or nail bed disease. Here's erythema and scale at the proximal nail fold, so you can see that there's psoriasis. And once again, onycholysis, and then pitting that's visible. So psoriasis with onycholysis is due to nail bed. This figure I remember, I think I just found on the internet, was kind of nice, just summarizing different phenotypes that you can see in psoriasis. So again, pitting, nail matrix, oil spot, onycholysis, both nail bed, sublingual hyperkeratosis, which you get debris lifting the nail plate up. Here you just have complete destruction of the nail plate. Here's a splinter hemorrhage, which is capillary bleeding. Non-specific, but can be seen in psoriasis. Here you get psoriatic nail dystrophy and then marked inflammation, and then psoriatic plaque. So I'm guessing, yeah, it's the psoriatic arthritis. Here, this pretty much tells you what it is. This is kind of end-stage psoriatic arthritis, the arthritis mutilans. You can see there's ulnar deviation to the digits, and then here kind of a telescoped appearance where the digit is collapsing in on itself. Here's the x-ray findings. Really, in my opinion, you should never be asked to interpret these, but this is the so-called pencil in a cup, where you get resorption of the distal bone into the proximal bone, so it looks like the proximal bone is inserting into the distal bone. It's a pencil and cup phenomenon. This is Warnoff's rings, really interesting phenomenon that you can see in healing psoriasis, particularly when you have psoriatic plaques that are exposed to phototherapy like narrowband UVB. You'll get this peripheral kind of blanching or hypopigmentation ring, and that's Warnoff's ring. This is blurry. I don't know what this is. Oh, Otspitz sign. Okay, so Otspitz sign is the pinpoint bleeding that you see in the psoriasis when you remove the scale. So this must have been a psoriatic plaque that had the scale scraped off and it caused bleeding. The reason is histologically you have a lot of high-riding perivascular blood vessels that are dilated in plaque psoriasis, and so that's why you see that bleeding. This is different. This is not psoriasis. This is papulosquamous, so it's raised and scaly. It's psoriasiform, but it's not true psoriasis. The key here is you see these scaly pink plaques, but then you also have well-demarcated follicularly based plaques. So very well-demarcated plaques that are coming out of the hair follicles, coalescing into these broad plaques. And this is like psoriasis, but it's not. It's pityriasis rubopolaris. Functionally, there's kind of the same thing. There's some weird genetic forms and associations with PRP, but from a clinical, histopathologic, and treatment standpoint, it can be approached from the same standpoint of psoriasis. This is PRP again. You know, a nice giveaways. You have these good islands of sparing here. So you have these papulosquamous areas and then these islands of sparing. This is the waxy keratoderma that you see, palmoplantar keratoderma of PRP. Is this EPD or what is? Oh, cradle cap, subderm. Okay. Oh, yeah, this is a baby. On an old guy, if you have this adherent scale, you can think of erosive pustular dermatosis of the scalp. but this is a young infant who has this confluent scale on top of erythema. So this is seborrheic dermatitis or cradle cap. I don't know. This is a patch of something. All right, pityriasis rosea. This is a zoomed in spot. Not great. You'd probably want to see it from a little bit lower power. Seeing that it's a herald patch, it's going to be distributed upon Christmas tree lines. Oh, here's a better picture of it. So you see that it kind of has this lateral raining down approach of along the Christmas tree pattern for pityriasis rosea. This looks like carp. So you get reticulated brown patches on the upper back. Oh, and this specific variant is pseudoatrophoderma caule. It's basically a variant of carp where you can get some atrophy. Looking at this codachrome a little bit more quickly because I'm kind of just rushing through. You can see a little bit of shininess here, and the shininess indicates that there's either sclerosis or atrophy. And so the reticulated brown hyperpigmentation along with atrophy, this is pseudoatrophoderma caule, which is an atrophic variant of carp. This just looks like atopic derm. You get eczematous papules and plaques. Denny Morgan lines. Oh, so it's emphasizing these Denny Morgan lines, which are these kind of over-exaggerated folds under the eyelid due to over time edema that's building up there, causing the eyelid to fold upon itself. So that's a sign of atopic dermatitis. This is really interesting, actually. I've seen this a couple times in practice. This is called white dermatographism. It's seen in atopic dermatitis, and basically what happens in patients with atopic dermatitis, there's dysregulation of the T cells and cytokines in the skin, and when they scratch, there's a vascular steal phenomenon where there's so much vascularity peripherally, you get central blanching, and you'll actually get what looks like to be dermatographism, but instead of it being red and welty and raised, it's actually white. So it's white dermatographism. That's medium to low yield for boards, but kind of interesting. This is the couple more signs of atopic dermatitis. This is where the person gets this allergic shiner, and this is where the kid is just kind of pushing up their nose because they're itchy, what's it called? Allergic salute. This is dyshydrotic eczema. Look at those nice frog spawn vesicles, tapioca-like vesicles on the finger, dyshydrotic eczema. This is nummular eczema. Nummulus means coin-shaped, so oval-shaped, coin or oval-shaped patches, typically on the extremities, lower extremities. Contact dermatitis, I think, because it's linear, horizontally oriented. This looks like phytophotodermatitis, so you get these kind of quasi-linear, bizarre, hyperpigmented shapes. This one specifically Berloque. Fissure dermatitis, like hand dermatitis, it looks like. Oh, and interesting. So it shows that this person was touching a garlic clove. So, you know, this is fissured hand dermatitis, possibly contact dermatitis, because they're holding like some type of food that makes them allergic to it. I think the classic board description is in the second to fourth fingers. First through third fingers second through fourth fingers that are most likely to grip or hold food. Asteatotic dermatitis, aka Witter's itch, has this cracked and dried riverbed appearance to it. This just looks like lipodermatosclerosis, stasis dermatitis. Note the inverted champagne bottle or wine bottle appearance. You can tell if you palpate this, it's going to be firm. This is lipodermatosclerosis. This is completely different. This is hemorrhagic stomatitis. So you see inflammation, reddish, kind of bloody discharge to the lips. This is a differential diagnosis. I don't know if my next slide has something in terms of what this clinically is, but you can't look at this and say what this is. It's a differential. It can be reactive. So you can think about SJSTN in the most extreme form, reactive and infectious mucocutaneous eruption, RIME, formerly known as MERM or EM major. They're all the same thing. It can be infectious VZV, HSV. Contact stomatitis can look like this. GVHD can look like this. Perineoplastic pemphigus, oral lichen planus, mucous membrane pemphigoid, bullous pemphigoid, chemotherapies. So basically, it is a differential diagnosis that you have to walk through based on your history and exam. Okay, so in this case, apparently this person had targetoid lesions, so it's EM major. Let's see, papillonecrotic lesions that are leaving scarring. I don't know, it makes me think of varicella. Oh, pleva. Okay, well that makes sense, right? So pityriasis lichenoides varioliformis acuta. So basically it's so named because it kind of looks like varicella. It looks like a viral infection, but what happens with this is it's more of a T cell mediated response. Then when it leaves, will often leave these chickenpox-like scars. This is random, apparently, this is mentioned, but if you have someone with a vesicular bullous disorder, there's different ways or signs to kind of study them or kind of investigate what's going on. The Nikolsky sign is when you rub laterally on the epidermis and you get shearing of the epidermis from the dermis. You can see it in Stevens-Johnson syndrome. Aspo-Hansen signs when you push on a blister and it spreads laterally. Here you have a well-demarcated violaceous patch with peripheral erythema, super oval. This is fixed drug. Nothing else can look like this. Is this PRP again? Let me try to put it together. You get keratoderma, follicularly based. It's two interface though. It's very violaceous. PRP is going to be papillosquamous epidermal. This is interface and ear. Oh, okay. This is probably getting at GVHD. So you get follicularly based, kind of interface, purple-looking dermatosis. It likes acral locations like the ear and the hands, and it can become blistered. Yeah, this is GVHD. This is the other form of GVHD. So this is acute GVHD. This is going to be chronic GVHD, and this is the lichenoid form, where it looks like almost they've developed lichen planus because of their graft versus host disease. This is the sclerotic form, I'm guessing. This could also be scleroderma and other sclerotic etiologies in the clinical context, but I'm guessing we're in the chapter of sclerotic GVHD. This looks like regular lichen planus. Look at this nice reticulated lesion with Wickham striae. Here you get reticulated lesion. This is lichen planus. Okay, we're probably powering through some lichen planus variants. This is lichen planus actinicus, where basically you get these oval to annular forming plaques in Middle Eastern folks, typically on the face. Sorry, I went through that a little quickly. Yeah, actinic lichen planus. Probably bullous LP. So here you get these oval, scaly, pink to purple plaques telling you it's lichen planus, and then here they're blistering, but they're blistering within the lichen planus plaques only themselves, and that's because there's so much interface damage. It causes the max Joseph's faces, and then you get bullae that occur within that location. If there's enough damage, you can get liberation of P180, epitope spreading, antibody formation, and then you can develop blisters anywhere, and that's bullous pemphigoid, or lichen planus pemphigoides, which is basically bullous pemphigoid with lichen planus. I don't think that's what this is. This just looks like lichen planus again. So again, oval, scaly, purple plaques. Oh, it's drug-induced, and the point here is, here it's very generalized, whereas you think about regular idiopathic lichen planus favoring the flexors, here it's really generalized, which can be a feature of drug-induced. This is penile lichen planus, very common area. The key with lichen planus on the penis, it presents with these purple plaques that are very annular or ring-shaped, genital lichen planus. This is hypertrophic lichen planus. Lichen planus is very neat because in different locations it looks different. So here, pretibially, it has that igneous rock description of hyperkeratotic lesions on the shins. It does have a low but real risk of transforming to squamous cell carcinoma. This is, I mean, I'm guessing inverse LP. If I saw this Kodachrome and my brain wasn't primed for it, I would think about hidradenitis suppurativa, honestly, but I guess it's inverse LP. This is lichen striatus, I think, although this looks like an older person. Something lichenoid, because again, they're flat-topped papules and they're in Blaschka linear array. Okay, linear LP. Lichen striatus is a variant of lichen striatus is a variant of linear lichen planus that occurs in kids. Typically 10 to 11, I believe, on the extremity and can be associated with nail dystrophy. But in this case, you can tell with the hair and the veins that this is an older person. So this is linear lichen planus. Here is oral reticulated lichen planus. This is just non-specific nail findings. Ridging can be due to anything. Remember, nails manifest differently than skin. So if you have pathology here in the matrix, it's just going to manifest itself in the nail plate, but it's going to look different. So ridging basically is telling you there's some type of matrical abnormality, non-specific. This is dorsal pterygium meaning wing. Again, non-specific tells you that you have matrical scarring. So this is what a scar looks like in the nail plate. And, you know, the classic association was lichen planus, but it really can be anything. I don't know what this is. Maybe Kaposi sarcoma, reddish-brown plaques here, a little bit too much scale. Oh, we're still in lichen planus. Well, go figure. So I've never seen palmoplantar lichen planus look like this, but I guess it can. And one of the learning points, maybe this is highlighted in Alikhan, is that it can be erosive. Here's your bullous, here's your lichen planus pemphigoides, aka bullous pemphigoid. in lichen planus, and the key here is you get these lichenoid papules and plaques, which tells you it's LP, but then you get blisters within the lesions and also outside of the lesion. So this is lichen planus pemphigoides, which is BP and LP, and again, because of the reasons we already discussed. This is lichen planus pigmentosus. I've seen a few cases of this, which is a pigmented, often reticulated form of lichen planus that can occur on the neck. This is lichen planus in the hair, lichen planopilaris, and you get this classic perifollicular hyperkeratosis and then often dilated blood vessels. So lichen planopilaris. This is the same thing. This is lichen planopilaris, the variant often in middle-aged women where it causes this inflammation and frontal recession with eyebrow loss that you can see here is known as frontal fibrosing alopecia. Oh, this is one of those genetic syndromes you have to learn. I don't remember. This looks like lichen planus with scarring hair loss. I don't remember. Okay, Graham-Little-Picard-Lesour syndrome. So it's just something to learn, rote memorization. It looks like these people get LP-like inflammation in their scalp, so they get hair loss, and then they get axillary involvement, and then they get regular LP. So I guess I threw this here because it's probably a mental acre for me at the time. Hair loss, axillary involvement, regular LP. This striae, striae, but then this is Nickham's disease, formerly known as Nickham's disease. This is keratosis lichenoides chronica. Basically, it's a weird form of lichen planus where you get these reticulated papules and plaques that are lichenoid and can look like scars and striae. So at first I thought there was striae. I don't know what this is supposed to be showing. At first I thought there was a striae, but then the key giveaway that it's not is it's reticulated and there's a little bit of epidermal change. So this is very rare. I've never seen a case of this. This is formerly known as Nickham's disease. It's keratosis lichenoides chronica. Oh, and the description that they mention is that they can get SIBO psoriasis. This looks like LP again. LP pigmentosis, like ashy derm type of thing. Yeah, they're all the same thing. If you look at all these pigmentary disorders where you get this reticulated, photodistributed pigmentation, LP pigmentosis, erythema dyschromicum perstans, ashy dermatosis, they're all the same thing. Histologically, they're all characterized by lichenoid interface dermatitis with a lot of pigment incontinence, and that's why they look like that. It looks like this is transitioning to benign lesions. So I'm probably going to stop here because I'm losing steam as you probably are. I don't know how many slides I got in. Let me see. 100. Perfect. Stopped at around 105 and we'll keep going. Hope you enjoyed this video. Thanks for watching.